Welcome to the Hair Loss Show. Dr. Russell Knudsen and Dr. Vikram Jayaprakash discuss issues relating to hair loss and the medical and surgical treatment of hair loss in both men and women.
Hi everyone, and welcome back to the Hair Loss Show. I'm Dr. Vikram Jayaprakash.
And I'm Dr. Russell Knudsen. Welcome and thank you for watching.
Great, well welcome back. It's good to see you again, Russell.
Thank you.
Yeah, and it's good to be with you all again. So please remember to like and subscribe the channel. We're really gratified by the growth that we're receiving in the channel. So please, if you haven't subscribed already, please remember to hit that subscribe button. That really helps get the message out to everyone that wants more information about hair loss and all the information that we're putting out there on the topic.
And thank you for sending in the questions, and we'll attempt to answer some of the ones that get asked quite frequently because clearly people are interested. So today's topic is going to be on new trends in therapy. We're going to start with androgenic alopecia, or male pattern balding if you like, and we're going to talk about the use of topical therapies for treating it. This is an increasingly popular trend in management of hair loss. So historically, people have been treating male pattern baldness with topical therapies for thousands of years.
Yeah.
For example, in ancient Egypt, believe it or not, they used to rub crocodile dung onto the bald scalps. And one of the things that is probably relevant from then and relevant to now is that if you massage anything into the scalp, there are hairs, even in bald people, sitting there in a prolonged resting phase, that mechanical stimulation of any sort can bring some hair to grow out of a bald scalp. And this often sets people off on a false trail. So for example, there was a famous case about 15 years ago of an English farmer who had an interesting relationship with one of his cows. He was very bald, and the cow used to lick his bald scalp. And after 6 months, he had a few hairs sprouting on his bald scalp.
Right.
So he made the logical assumption it was something in the cow's saliva that had stimulated the hair growth, rather than the fact that the rough tongue of the cow had stimulated some of these resting follicles back into life.
Yes.
So there is a long history behind mechanical stimulation or topical applications to the scalp and baldness, but very little science until recently.
So I think what we want to do here, what we're trying to achieve is to almost get a recap of what there is out there, because we've talked about a lot of this before, but it's sort of packaging it differently so everyone understands what we're talking about, and potentially in part 2 of this talk about newer therapies as well.
Right.
So when we talk about when someone comes and sees us for a consultation, we will we'll obviously look at the diagnosis, and in this case, let's say the diagnosis is androgenic alopecia. Okay, what are the treatment options? And there's different arms of treatment options, and we've talked about this in the past. One of the common things that we use is stimulation therapy, and so the most common stimulation therapy that we sort of make use of is minoxidil. All right, and so minoxidil actually acts in a way to improve blood supply to the area. It stimulates the hair growth, essentially making that hair that little bit thicker.
Yes. Now, the interesting thing is that we've been researching minoxidil for approximately 40 years, and we still don't know exactly how it works. It was originally used orally as a treatment against high blood pressure, and in the doses they were using, and 80% of the people that were using it orally got increased body hair growth, which basically, pardon the pun, stimulated the interest into seeing if they could use it as a topical therapy for baldness. Now, the philosophy of topical therapies is clear.
Yes.
The idea is you don't want to provoke, via stimulation, hair growth elsewhere, particularly in women, but also in men. And so the idea is that you localize the effect to the area that you want to treat.
Yes.
Rather like we do for creams for rashes and things like that. So the logic of it, philosophically, makes sense. And also, a lot of patients that come and see us seem more comfortable with the idea of at least doing something as a local therapy rather than doing something as a general therapy. We've got to remember too that our patient population in general are younger, healthier, not used to taking anything.
Yes.
Right? And they don't want to see themselves as suffering from a disease process and therefore requiring lifelong therapy in the conventional sense. So anything that actually acts in sort of a local manner is appealing to them.
So I think that's the important thing, that we're sort of seeing, not necessarily shift, but we're seeing that interest in people, how people perceive the medication that they're taking. Instead of wanting to take something systemically, they like the concept of being able to take something that's a little bit more localized in its action. And certainly with stimulation therapy, with minoxidil, you can either have it orally or you can use it topically
Now,
as
the
well.
interesting thing about minoxidil is that because it was a bit hit and miss in the way it worked, it took a long while for the penny to drop. The part of the reason for that is that minoxidil is not the active medicine itself. It has to be converted into minoxidil sulfate inside the skin for it to actually exert its effect upon the hair follicle. And it appears genetically that only about 50% of men have enough enzyme to get a clinically effective level. And that's why the results in some people were good, in others were disappointing. So the irony of that is that we have moved rather more towards oral minoxidil in recent years, because there's also another enzyme in the liver that helps do it. And we seem to get better results in a lot of our patients. Not all of our patients, but in a lot of our patients we get better results using oral minoxidil. But nonetheless, the logic of using localized stimulation is okay. And it appeals to people. So basically that is where we started, was on the stimulation side. And then of course with the advent a decade later of the enzyme blockers, and I'm not going to call them DHT blockers because I want to remind the audience that we're not talking about DHT blockers, we're talking about an enzyme 5-alpha reductase blocker when we talk about finasteride or dutasteride. It's wrong to call it a DHT blocker because that makes people fearful that we're just blocking the effects of hormones on the body. And we're not. We're blocking the enzyme that's converting testosterone to dihydrotestosterone. So the testosterone stays high and the DHT goes low.
So we have testosterone gets converted into dihydrotestosterone, and then there's the 5-alpha reductase enzyme that causes that conversion. If we block that enzyme, you block the conversion of that to that, and you lower that in the system.
And you raise that.
Yes.
The testosterone goes up. So this is part of the fear we get asked every single day of our working lives about the potential side effects of finasteride because of the massive scare campaign on the internet about the sexual side effects, which are uncommon, but do exist.
But the other thing to mention is that we're not in the business. The goal is not to get this down to zero.
No.
Right?
No.
We want to lower it below a certain threshold level. Now that threshold is different for you as it is for me, as it is for the next person. And that's where, when we talk about customizing therapy, that's where that comes in, because we need to find out what is the minimum dose.
We don't need a sledgehammer to crack the nut.
Correct.
So if we have an older patient with less hair loss, we don't need much medication at all. If we have a younger patient with a lot of hair loss, we may need to be more aggressive in our therapy. So again, when the enzyme blockers came into the marketplace, this is finasteride in 1997 in America, 1998 in Australia, and dutasteride, which is 2011, which is a little bit stronger than finasteride. They came on as oral medications. They had a previous use in prostate enlargement, non-cancerous, by the way, and it was found by circumstance, if you like, that they were treating prostate enlargement and watching people with baldness recover some hair loss, and that was the tweak to actually think about that it had a second purpose. So it came on as an oral one. Again, because of the fear campaign and justified fear in young men of sexual side effects. A lot of men asked us, well, can't we do it topically rather than do it systemically? Do I have to really put it into my body? I'm not used to taking anything. I prefer not to do it systemically. So in recent years, it's become more popular to use topical finasteride and recently topical dutasteride as enzyme blockade. So again, this comes back to the concept of localizing the effect to where you do it. Now, the plus is it localizes the effect. I guess the minus is compliance becomes an issue.
Yes.
Because we find with a lot of patients, they come in and they struggle with doing it regularly. when you do it. It's a lot easier to take a pill than it is to be applying it. And they don't know how much to apply and where to apply it. So I'll remind people that if you're going to apply topical therapies to a bald area, you're wasting your time. If you're going to apply topical therapies, you apply it to a thinning area, because there has to be some hair there for it to work on. A bald area is not going to respond.
Yes.
So you apply it to the thinning area, not to the bald area.
So just to recap on that, because I think that's a fundamental thing that a lot of people misunderstand. I mean, if we look at androgenic alopecia and we look at someone who's balding, well, the histological definition of androgenic alopecia is also loss of the stem cells and the bulb there. So if you haven't got any stem cells there, if there's no root there, then applying all the finasteride, all the minoxidil, all the topical dutasteride, all the livelong day, or even taking it orally, you're not going to suddenly grow new hair.
Well, this comes back to one of our other videos about the 50% rule that you did.
Yes.
Which emphasises that there has to be sufficient stem cells in the hair follicle for anything to work. And that means you've got to get it early. The later you treat, the less you regain, in a sense. So basically, you can look at topical therapy is stimulation or blocking. That's the two things. Now, blocking can be done, as we've just described, in topical therapy, but more recently, and this has often come from research done in Europe and South America, where it's quite popular. We have this new thing called mesotherapy, which is becoming increasingly popular. And mesotherapy means injecting very low doses of these medications directly into the scalp. So it's another version of a topical therapy, but this time it's invasive in the sense that it has to be injected. So there's a lot of work being done at the moment on injecting finasteride, for example, and injecting dutasteride into the scalp. Now, the advantage of it is that you can do it quite intermittently, because, for example, with dutasteride, they say, well, you may not only need to do it every 2 months.
Yes.
Or with finasteride, every month or every 6 weeks. Why? Because the half-life of that medicine in the skin is so long. So I just want to emphasize again that it's proof of concept to us of what we've been talking about since the start of our series of videos about why we're using daily finasteride, why we're using daily dutasteride, even orally when it has such a long half-life. So if you can use it topically every 6 to 8 weeks, why are you taking it every day orally? It makes no sense.
Yes, more is not always better, in fact. And so I think that is probably what a lot of people find beneficial about it, is that they don't have to remember to take something on a regular basis. So they don't feel that they are on regular medical therapy. They come in intermittently for treatments. The risk of potential side effects, and there's not a lot of powerful studies that have shown the benefits of certainly, topically, but certainly mesotherapy use of finasteride or dutasteride. But the studies that are there, the research that people that are using it regularly have shown, some good benefits from it.
So it's basically an evolving trend that we give more options to patients, I guess.
Yes.
That we have proven drugs, like minoxidil is a proven drug, finasteride is a proven drug, dutasteride is a proven drug. So if we've got these proven drugs, and if we find just different ways to offer it to people that make it more palatable in an effective way for them to use it, then it makes sense to do it. So this particular version of the video is going to be with the therapies that we already know a lot about.
So I've got a question, and I don't know the answer, so I'm genuinely asking this question. So how about something like a topical finasteride or topical dutasteride? Because that's a different preparation than the mesotherapy dutasteride, for example, which is more oil-based. How about the use of that with derma rolling?
Well, again, the theory behind derma rolling is that you're increasing skin penetration, number one. And number two, by using derma rolling, you are setting off the natural body repair mechanisms, which by coincidence involve increasing growth factors in the skin as part of the repair process.
More blood flow to the area.
You're getting, and all of those things. So you're getting this stimulated response. So yes, the idea behind it is logical. Another thing to remember though about a derma rolling is that it's invasive, right? And therefore all of these invasive things are not without some degree of discomfort or pain, right? And one of the things that we get asked a lot about is the frequency of derma rolling. And people should remember that if you overdo anything, you do more harm than good. And so that's also going to be true for derma rolling, because remember, you're micro-injuring the skin each time you do this. So if you're doing this every day, you're micro-scarring the skin. If you put scarring into the skin, that doesn't help the circulation, doesn't help the normal functioning of the skin. So it's too much of a good thing. So I like to tell people, once a week's going to do the job, right? You don't do it more than once a week. Let it heal, let it settle down before you do it again.
And certainly if you're bleeding, then that's probably too deep as well.
Well, you've gone too deep, that's right.
But I mean, and sorry, veering back to what we were talking about, certainly with mesotherapy, one of the things that we do is we would certainly do it under localized ring block.
Yes, you can do that under local anaesthetic. So again, it has to be administered by a physician if you're going to do mesotherapy. Just remember that, because these are medicines, they're prescription medicines, and they have to be done in a medical setting. And they have to be done in a sterile setting as well, because you're injecting things into the scalp. So you need to be really, really careful about that to make sure that we've got sterile solutions and we aren't creating the potential for infection. So as long as it's being done in a highly regulated environment, it's a very reasonable thing to do. This idea of using topical therapies for either stimulation or for blockade, and doing it by mesotherapy, or doing it just by topical application of creams or lotions. Or
so basically what we're saying is that there's stimulation therapy, there's blocker therapy, and we can use it orally, we can use it topically, or there's the other option that we're seeing a lot more with is with mesotherapy as well.
And again, if you're using it topically in a non-invasive way, you can then combine minoxidil with it. It's going to be tougher to use the minoxidil in mesotherapy because the half-life of the minoxidil is less than a day, just less than a day, whereas the others are more than a month. So it doesn't really quite match up.
Good. Well, that was interesting. I hope that you found that interesting as well. I found that fascinating about the different ways of the modalities of getting the active drug into that localized area to give it that benefit. And in part 2, come back for that, because we're going to talk about this reaction, but further down that chain, and what we can do to modulate
and some
that.
new emerging therapies that are showing the potential for further development of topical therapies.
Perfect. All right. Well, thanks again for watching. We'll see you again on part 2. Take care.
Thanks very much. Take care.